and expertise is needed to perform them. In particular, I've seen some patients, one or two here and there start to make some decisions about, well, I'm going to try to get, a PICL procedure done over there because someone's claiming that they do it. Or I'm going to go try to get my C0C1 facet injection someplace else. And so I think it's important in trying to help patients stay safe to educate them about all that goes into these procedures. And it's not trivial at all. It's quite a bit. So we're going to go through that today. As usual, I'm going to do a quick discussion starter, and then I'll take questions. If you've got questions about what we're discussing, that's fine. If you've got questions about anything else, that's fine as well. Again, the purpose of this show on a weekly basis is to try to make sure that people get their questions answered so that patients get educated, because educated patients, in my experience, tend to get better quicker. And so again, if you're just joining us, we're going to be talking about why the PICL and upper cervical facet injections are so difficult, what kind of equipment you need, what sort of decision-making and experience is required, because all of that goes back to patient safety. Without much further ado, we'll jump into that. Feel free to start adding your questions there. And let's see here. Okay, let me share my screen. And now we will start the presentation. So why the PICL and upper cervical injections are arguably some of the most difficult to accomplish safely. And again, the reason why we're going through this today is because I'm starting to see a few patients here and there not understanding all the parts and pieces that go into these injections. I think most patients believe that if there's a procedure and someone's doing it, that pretty much any other physician can do it. And regrettably, that's generally not true. And it's really, really not true with these procedures. So if you get a chance, I want you to like, comment, share, subscribe, because that's how we get this information out to more people. So every time you like this video, you comment on it, you subscribe to the channel, more patients like you who have your kind of problems will be able to see this content in their algorithm. So you're not just, saying, I like this, you're saying, hey, I want to get this information out there to more patients. So I've seen a few patients who are having unqualified physicians inject their upper cervical spine. This is scary to me. I kind of scratch my head and say, maybe it's because they don't know all that go into these procedures. So I'd like to kind of go through some of that today, and then after that, we'll take questions. So we're going to discuss two procedures today, C0C1 facet injections and the PICL, EPICL procedures. So C0C1 facet injections. This is probably arguably the most difficult traditional spine injection to do, meaning that if we take 1,000 spine interventionalists who routinely do all areas of the spine, have been trained to do all areas of the spine, we probably only have about 100 of those that will even attempt this procedure. And then of that, we probably only have 10 of those that have done it a reasonable amount of time in their career. And we probably only have one of those who actually does this enough so that they feel comfortable doing it on any given day, meaning they might do it 20 times a year. Still not a lot, but at least they're doing it enough to understand how to adapt the procedure to the different anatomy you can see. So why is this one so difficult? You can't see the entry to the joint on fluoroscopy. So you have to estimate where that entry is. And the traditional procedures, they teach you to do this, regrettably, are even worse, right? I developed my own procedure to do this. Hopefully some providers have adopted it, which I think is far safer, far better. But the traditional procedures they teach you in the coursework are semi-dangerous in my opinion, meaning they're not fully baked because most doctors don't do these. The other reason is the vertebral artery lies across the joint, so you can inject into the vertebral artery. If you inject some contrast, no harm, no foul. If you inject an active solution, anesthetic, corticosteroid, platelet-rich plasma, bone marrow, that could be a big problem. And the fluoroscopic anatomy is confusing unless you look at it all day. So this is what it looks like. And you see lots of overlapping shadows, and it's hard to interpret even for experts that do spine injections all day, every day. The added equipment you have to have isn't trivial. You have to have digital subtraction angiography, and that's usually only found on CRM fluoroscopes that are being used for cardiology. So interventional pain doctors generally don't have access to fluoroscopes that have this digital subtraction angiography, and this is what it looks like. Let's see if I can get this to work. Oh, it's telling me it can't play media. Sorry about that, guys. But anyway, you get the idea. What digital subtraction angiography does is it allows you to see exactly where the contrast is going to make sure that the contrast doesn't go into that vertebral artery, which supplies brain to or blood to the back of the brain. And as far as doctor decision-making, I want to go through some of this because it's very important. The first one is obviously obvious. Do I have the right equipment? The answer 99% of the time is going to be no. Even in doctors that are doing this procedure that don't have access to a C-arm that has digital subtraction on it. Can I interpret the complex anatomy among the overlapping shadows? Again, even among doctors that do spinal injections all day and look at the spine in 3D all day, they don't really understand this area, or it's easy to become confused as to what it is they're looking at. Can I alter my procedure based on the unique anatomy like arthritis in the joint, a low skull base, or aberrant positions of the vertebral artery? These are all key things that you only learn through lots and lots of experience in doing these procedures. How do I alter my trajectory of the needle if there's a low skull base in the way, for example? Do I have to change the patient position? If so, how do I change that patient position? Another one that's not on here that I thought of while I was just hiking a moment ago is your rad tech, right? You have to have a radiology tech who understands what it is they're looking at, because many times that rad tech is another set of eyes on what it is you're looking at. Another one is the contrast being injected before the orthobiologic going in. Is it actually going into the vertebral artery? Key point, right? You've got to keep very close tabs on where your contrast is going, which is not something doctors are usually used to doing with these kinds of procedures. And if so, how do I reposition the needle to stay clear of the artery? And does the joint leak? Because if it leaks into the epidural space, that can cause someone to stop breathing if I'm using anesthetic. So these are just some of the things that have to go through your mind. And some of these you can teach, and some of these only happen after doing hundreds of these procedures. Here's a recent tragic case. I've talked about this case a number of times. It's winding its way through the court system right now. This was a CCI patient. I was the one that told the mother not to take this patient outside of Colorado for this injection. They did it anyway. The patient was a very hard to position patient, and the doctor, near as I can tell, in my opinion, became confused by the anatomy and what he was looking at in this particular case, and inadvertently stuck the needle into the brainstem instead of the C0C1 joint. A brainstem stroke then happened. Now, this patient was already very disabled being a CCI patient, but now they're even more disabled because of this problem. So as I said, this is not theoretical. This happens, meaning inexperienced providers can cause big problems with these procedures. So now we're going to get into the PICL and EPICL. And this is just the 30,000 foot here. So we've done around 1,600 of those procedures. I've done about 1,000 of those 1,600. I've redefined the ligamentous and bursal anatomy that appeared in textbooks because it was poorly defined, meaning that we've learned more than the anatomists know about this area because we're injecting it all day, every day in multiple different types of patients. And it takes several hundred observations, meaning several hundred procedures, to iterate and advance the procedure. So a good example is the recent EPICL variant. There have been other variants. I might need to do 100, 200 procedures before I notice, hey, if we just did this a little differently, we can make this better. And I'm still noticing some ways to improve this procedure, although it's probably 95% baked. So equipment needed. You need 2 simultaneous C-arms, 1 AP and 1 lateral, and 1 with digital subtraction. So here in the picture, you see 2 C-arms set up at the same time. How many physicians have access to 2 C-arms in one room? Almost none. It just doesn't exist out there. And it is difficult to even set up, right? If you want to try to borrow a C-arm from one room and move it into another, that's difficult for a couple of reasons. One is most places that do these procedures only have 1 C-arm. They don't have 2. Even if they have 2, you've got to bring them in one room and combine them in a way that makes sense, which is not trivial. You also need to have an endoscope. So these are questions you should be asking anyone claiming to do a PICL. Do you have 2 C-arms that you can use that live in the same room and you're used to using them together? Do you have an endoscope so you can see exactly where the sterile field is and how to maintain it? A 3D printed mouthpiece needs to be used, and you got to get the right one for that patient. We have different models we use. We have different sizes we use. All of those need to be radiolucent. I've seen some people trying a PICL where they're using metal mouthpieces that have been designed not for this, but have been designed instead for ENT doctors. And they're obscuring part of what it is you need to see because you can't x-ray through the metal. So you got to have a radiolucent 3D printed mouthpiece that's the right size for that person. The anesthesia provider needs to have experience to know what to do when someone's working through the airway. They're not used to doing that. They're not used to having to manage the procedure and to manage and to work with the doctor that's doing the procedure to manage the airway. There are specialized anesthesia medications that need to be applied that aren't usually used in pain management or spine cases. And finally, you have to have what we have in Colorado, which is a CGMP air handling lab, which in of itself costs several $1 million to keep the blood and bone marrow hyper sterile, not a convenience kit sitting on a bedside. Because the problem with this procedure is where you are injecting does not play well with an infection. We haven't had any deep infections. And the reason is that we've got a several $1 million lab where this stuff is processed, not a little bedside unit sitting on the bedside that someone puts a little kid into. So these are all the things you need to do this safely. Experience. A spine interventionalist who's already done hundreds of C0, C1, and C1, C2 facet injections under fluoroscopic guidance with contrast and digital subtraction. We're now narrowing the pool of people who could do this worldwide to maybe this amount that I can count on both hands. You've got to then have one-on-one supervised training on this procedure from myself over several months. Not a weekend course, not a see one, do one, teach one. And again, that's the problem we've seen. Both providers who claim to be able to do this tried to do a see one, do one, teach one. Those were 2 providers in Europe who watched 1 or 2 of these and then believed they were expert in it. They're not. We've had another provider who's never even seen one out in Asia and tried it as well. And again, you've got to have years of experience treating hundreds of upper cervical and CCI patients because these patients are not like your regular spine patients. You need to be able to identify, this guy's dizzy, this is what the injection targets are. This guy has problems with symptoms that get caused every time he looks up. This is what the injection targets probably are. And you've got to have excellent hands-on exam skills that go well beyond what most interventionalists bring to the table. And then physical exam and imaging review, and this is key, right? The patient has to be CCI subtyped using the subtyping that I created in order to identify the targets, the injection targets that you need to hit. Then the imaging has to be read by the provider in the room in front of the patient, and that's combined with the physical exam and the patient's complaints to identify those targets and to hone in on what needs to be injected. So if someone is just reading some report, that's below the standard of care for this procedure. The doctor doing the procedure needs to be able to read all the films themselves. They need to understand all the controversies around what identifies instability and what doesn't, what the literature backing is for each one of those, to decide how to choose these targets and who's unstable and who's not. And then a hands-on exam usually takes about 30 minutes, with much of that palpating every possible structure that could be identified as a possible injection target. And that's just not what most physicians do these days. It's because they live in managed care settings. They've got to see a patient every 5 to 10 minutes, and they never develop those exam skills that are needed to do this kind of complex procedure. And then in procedure decision-making. So you've got to be able to identify those less is more patients who are centrally sensitized. You got to know which type of 3D printed mouthpiece works best in this unique patient. You got to know how to prep the patient for that, because that's going to make a big difference as to whether or not you'll be able to even do the procedure. You've got to be able to manage the patient's oxygenation during the procedure with frequent procedure stops in some patients. And you got to work hand in glove with the anesthesiologist to know when you, as the injecting provider and your assistant, need to intervene in the airway to keep that patient safe, versus when the anesthesia provider needs to intervene. We do that all the time with the anesthesia providers we have. You got to figure out how to position the patient to keep the airway open while maximizing the access to the target. And you've got to figure out which procedural variation, and there are several within the EPICL spectrum, that go with this particular person's anatomy. So if someone has bone spurs on the atlas, how do I navigate around that to get to the ligaments I need? Not something that anyone else knows outside of yours truly and the people that I have trained that are in the Colorado office. You also need to know if the ligament spread pattern is consistent with the intended target. What does it look like when I cover the full alar ligament? What does it look like on AP and lateral fluoroscopy? What does the transverse ligament look like on AP and lateral fluoroscopy to make sure that I am in that ligament? There's no textbook you can go to learn that. That is only, again, myself and those who I've trained. And one of the key pieces of this that has become more and more prominent over time is, am I in a bursa? Meaning that we have redefined and we now fully understand what the upper cervical bursal anatomy looks like. It's poorly described in the literature. So you've got to be able to identify when you're in a bursa versus when you're in a ligament. And that's not something that it took me 600-700 procedures before I could accurately, with 100% certainty, say, I'm at a bursa and I need to get out of that bursa and get into the ligament. And here's how to do that. Again, not something that anyone else outside of Colorado understands. And the reason for having that discussion is if you inject into a bursa, you'll get some good temporary results, but you're not going to help that person long-term because you did nothing for the ligament. So in summary, there's nobody outside of our Colorado office who meets all of these requirements for safe performance and also knowledgeable performance of these procedures. Choosing a provider doesn't have the right equipment, training, or experience to do something like a PICL in my humble opinion, is just asking for trouble and large amounts of uncontrolled risk. Not to mention the procedure not working because they're not even injecting what it is they think they're injecting. And we're now getting to the point where I've trained multiple providers in Colorado. And at some point over the next 1 to 2 years, we'll get to that point where we can start to train providers outside of Colorado. But there's more to be done here, meaning there needs to be a big peer-reviewed publication that I'm working on, and that needs to get published. And then it's going to be few and far between, right? I will handpick these providers, and these providers are going to have to make an immense commitment to me to spend much, much more time learning than they're used to. They're used to going to a weekend course and they're good to go, or watching 1 or 2 done by someone else and they're good to go. That's not going to happen with this procedure ever. Why isn't it going to happen, this procedure? Because this procedure could easily go from safe and helping patients to being unsafe and hurting patients if all of those variables aren't controlled. Okay, let's start taking some questions here. See what we got. So get rid of the screen share and questions. So what's your take on the Activator for neck adjustment? For CCI patients, I don't think it's a good fit. I think you need to stick with AO and or NUCA providers. I would not use an Activator for neck adjustment in a CCI patient. John Gardner, how could a PICL help muscle spasms, not only in the neck, but the body? I think what you're asking is can a PICL procedure reduce irritation of the spinal cord, which could cause muscle spasms in different parts of the body, or reduce proprioceptive problems, which could cause other issues like muscle spasms. So the answer is yes, we've seen that. Your opinion, best treatment for a pinched nerve. My nerve ablation is wearing off. Radiofrequency ablation doesn't treat pinched nerves. It treats irritated or arthritic joints. The best way to treat an arthritic joint in the neck or a damaged joint in the neck is to inject orthobiologics into the joint. Radiofrequency ablation is not something we recommend at all as a treatment in 2024. It's destructive. It destroys the nerve, which causes more problems in the joint over time. So I don't recommend doing things that destroy joints, which is what radiofrequency ablation does. We only recommend doing things that help joints, which would be targeting an arthritic or damaged joint with an orthobiologic. My doctor gave me 10 days of corticosteroid pills before we proceed to steroid injections in the facet joints. My pain is better than pills that mean it respond good to injections. That's a really bad idea, Aman. Oral corticosteroids can be very, very helpful in the right clinical situations, but they have so many serious side effects that they should only be used at this point in situations where you're trying to save someone's life. So if someone has COVID-19, is in the ICU, or if someone would otherwise have disabling symptoms without the corticosteroids, and the long-term chance of corticosteroids hurting them is less than the severity of their disease, which is pretty rare, right? Because these are meds that can cause every single bone in your body to turn to mush. That's called osteonecrosis. So you got to make sure that calculus is correct. So no, that's a bad idea. The other reason it's a bad idea is oral corticosteroids increase infection risk. So by taking oral corticosteroids before you're injecting corticosteroids into a joint, you're increasing the risk for infection from that injection, probably by several times. And then finally, injecting corticosteroids into a joint destroys the joint and hurts the joint. So it's not recommended again in 2024. In 2024, we try to inject things to help the joint, which would not be corticosteroids. Submitted advance by John. Is PICL for lateral overhang at C1 the only way to treat the patient? Why do so many other providers insist there's other ways of treatment? Yeah, so I can only say that, we treated patients with lateral overhang at C1, C2 for many, many years by trying to inject the joint capsule, inject the joint, inject things around the joint. And the results were awful, meaning that the results were 1 in 5, which is less than chance, right? 50-50 would be chance and placebo effect. Why were they so bad? Because we weren't really getting into the ligaments. One of the reasons why I developed the PICL procedure was to help that specific patient population, because there was no other way to help them. Now, why do providers argue they can help? I think, A, they don't really know any different, right? They don't treat a lot of upper cervical patients. They're just looking to procure a patient that's willing to pay them cash. And number 2 is I think that they don't have the expertise to do anything like a PICL procedure. So if you have a hammer, everything looks like a nail. But no, it's not the right way to treat C1, C2 overhang. Now, listen, if you did 8 to 12 prolotherapy procedures and you got someone and you had them wear a cervical collar for months, what you're going to end up with is a patient that can barely turn their head. So their C1, C2 overhang might look a little better because they can barely move their head now, but now you've created a new set of problems that then have to be fixed. And as soon as you fix the range of motion issues, the overhang comes back. So there's ways to play the game and make it look like you can do it, but it involves hurting the patient's overall function. I mean, he said, we'll do some steroid injections of facet joints, then do PT. If no improvement, we'll move to PRP. Is this procedure right? No, it's not. You don't start with corticosteroid injections because corticosteroid injections damage the joint. You start in 2024 with orthobiologic injections to help the joint. The PT part is great. That can be very helpful. But again, high-dose corticosteroids injected into any joint, whether it's a facet joint, a knee joint, a thumb joint, destroy the joint. So you don't want to inject something to destroy the joint and then later inject something that will help the joint. It's like going this direction and this direction at the same time. It makes no common sense. Would it be a good idea to try to get off of NSAIDs? Yeah, NSAIDs are nasty, right? If you have to be on one NSAID, naproxen or naproxen seems to be the best of the bunch, but they all cause pretty serious cardiac side effects and also cause other side effects. So you really ideally want to get off NSAIDs and on things like curcumin, high-dose fish oil, because those are things that aren't going to have the downside side effects. In fact, they've got upside other things that they can help. But I would say NSAIDs would be a bad idea to be on long term because of all of those serious side effects. Plus, the NSAIDs are reducing your ability to heal, and you don't want to be in that situation, right? You don't want to be taking medications that reduce your ability to heal. Jessica, max amount of time it takes for ligaments to heal, then expect no more healing. It depends on the ligament in my experience. Some of these axial spinal ligaments in here that you can reach with Prolo will take 4 to 6 weeks, maybe 8 weeks to respond. Upper cervical ligaments take longer to respond, 3 to 4 months. But suffice it to say that 80% of what you're going to get is probably happening within that first 3 to 4 months. Some patients take even longer to heal. I've got patients that tell me that they don't notice improvements until 6 months or after that. So it's dependent on the patient, but for most people, 3 to 4 months should be where you would get 80%. And then you see remodeling that happens over longer periods of time. Rishi, last week you mentioned the name of an AO in Denver that you referred patients to. That was good. You mentioned it was female AO. Can you advise who you're referring to? Yeah, let's see. I'm blanking on the name right now. But Rishi, I think you've got my email address. Just send it to me. I'll give you the name once I look it up. Regenetics been advanced by John. If the success rate of PICL is 70%, what is the success rate of posterior injections? John, it just depends on what it is we're treating. But if we're talking about treating a C1, C2 overhang like your prior question, it's only about 1 in 5. So 7 in 10 versus 2 in 10, basically, for those two different types of procedures. Andreas, how did you become aware of the topic of CCI and what was the process to get involved medically? Yeah, Andreas, I got involved in a very interesting way. It's in the book, I think. There was I was a new doctor who had just come out of residency, and there was a local audiologist, an older gentleman, who was an old-timey audiologist that did ENG, electronystigmograms, and he was an expert in ENG. And way back in the day, unlike today, when you got ENG results, you had to interpret them yourself. Now it's all done by computer. The problem is the computer stuff kind of hides, insight, right? It either says, yeah, this is normal or abnormal. With him doing the data analysis himself, he could clearly see that he had a patient population, and the patients that were sent to him, most of them who had been involved in car crashes, who probably were having upper cervical influences on their dizziness, because he was seeing dizzy patients. He was doing these ENGs. So he came to me, I think I called him about an ENG result because I didn't really know how to interpret it. I was a young doctor, so I said, I'll just call this guy and see what all this means. And, he recognized, I think, immediately that I had the ability to treat these patients, and that I, being a young doctor, had an open mind rather than a closed mind. And so we kind of got together, and he's the one that started then flooding my practice with all these upper cervical patients. So that's how that worked. Virginic, submitted advanced by John. Some patients in CCI Facebook groups report getting worse after PICL. Why could this be? What percentage do you think patients get worse? As far as permanently worse, it's a really, really, really small number. I would say that right now, in my current iteration of the procedure, I haven't had a patient get a report that they're permanently worse or even long-term temporary worse in quite some time. Now, again, I've done 1,000 of these procedures, and I know who to take the less is more approach in and who to hit harder. And so that experience obviously comes with doing 1,000 of these procedures. So I'm not quite sure where that's coming from. I had someone bring that up just recently who was in the office, and I said, you must be looking at squeaky wheel people, because I've actually, I don't see that at this point. Meaning, the squeaky wheel people are screaming and yelling versus the people who are not. So not quite sure where that's coming from. As far as long-term flare-ups, at one point during the procedure, when we couldn't accurately identify out the less is more patients, I would say that we probably had about a 1 in 20 long-term flare-up rate. I would say right now with EPICL and identifying out those patients, that's gone down to less than 1 in 100. And those are patients that flare for 3 to 6 months and then get to the other side. In fact, I just had one of those patients who is one of the early long-term flares did quite well with the procedure. Hernia, PRP injections down in my lumbar area, L3 to L5, S1 by a Regenix trained physician. I had severe lower back pain. I couldn't walk, stand or sit down for days. I got an MRI done and all herniated. Not sure what that means, meaning that there's nothing about these that would cause disc herniations. So if you had a big flare up for several days, that usually means that you've got a systemic inflammation problem, meaning metabolic syndrome. So that's more likely to happen in people who are middle-aged, overweight, have problems managing their blood pressure. They're borderline diabetic, meaning they're not diabetics, but they have poor blood sugar control. Those are people who tend to have those sorts of responses, and it's usually due to their systemic inflammatory makeup. But there's nothing about those procedures that would cause anything as far as disc herniation. So my guess is anything you had was there before. Regenix been advanced by Sabina Saleh. I would like to submit a question, Dr. Centeno. Be okay to use to stand in a cryo chamber between repeated PR injections if you wait 3 months, or could you extreme cold still compromise the proliferation process past 3 months? Yeah, I think that's fine. There shouldn't be a problem at that point. maybe all back to normal, but still experience pain when sitting down in sciatica. Yeah, Hearn, I need to look at all your stuff to be able to comment further, right? It all would depend on where the disc bulges were, exactly what was injected, why it was injected there, what was injected there, how all of that interacts with your physical exam, all of that good kind of stuff. What could be causing it if the herniation is gone? Now I'm super confused because I think you said you had herniation. So again, this is stuff that'd be better for a telemedicine appointment where we can go through all of this and really understand what's happening with you. If it's a mistake, he injected steroids in my VA, I will die on the table. No, you won't die on the table. Hopefully not. No, steroids don't kill you. They just inhibit healing. And they have lots and lots of side effects. So no, I don't think you'll die on the table or anything like that. I think you mean Veterans Administration, but I'm not quite sure in context what VA means there. Out of those 1,000 procedures, do you have repeat DMX? How many of them actually had fixed ligaments versus just feel better? Yeah, Brian, we only repeat the DMX when there's a need to repeat the DMX. And that actually started right here, right on this channel. We would routinely repeat the DMX early on, and I had so many patients that were complaining about X-ray exposure that we decided to change that protocol and say we'll only re-DMX if there's a clinical need to. So I would say of those, how many have we gotten repeat DMXs on? Maybe 100 or so, meaning only when we needed to get a repeat DMX. So we probably had the first 20, 25 where we got repeat DMXs, and then we went to the new policy. And since then, I don't know, maybe 100, 150 have had repeat DMXs. The percentage of patients that have improvements is very high within that group, but it's not an all-encompassing group, meaning we don't do it specifically because a patient complains about X-ray exposure. I just had a conversation this week with a patient online via email who I want to get a repeat DMX on, but she won't do it because of concerns about X-ray exposure. So welcome to my world. That's my world. Ever thought about training a surgical robot? Seems like for delicate PICL procedure. Nah, there's no way that a surgical robot could do this at this point. That'll change at some point, maybe in the next 5 to 10 years. But you'd need pretty much AGI, artificial general intelligence, which doesn't exist right now. We've got very, very narrow algorithmic and narrow AI at the moment. AGI would be something equivalent to a human brain. We don't have anything close to a human brain at this point in 2024, nor do I think we will for another 5 years at least, if not 10. Because there's too many parts and pieces you would have to interpret and understand as the artificial intelligence to know what to do next in this kind of procedure. What's better for chondrochondritis, PRP injections, or steroids? Again, I don't inject high-dose corticosteroids any place in the body at this point in 2024. It's inappropriate in my medical opinion. Primarily because it causes local tissue death. And we shouldn't be doing things that kill tissues in 2024. We should be doing things that help tissues. So PRP injections all day long and twice on Sunday for that one. And today's Sunday. Robert, question. Couldn't see the PICL clear. Is your fluoro, you have single C-arm with 2 X-ray tubes or 2 separate machines? Yeah, 2 separate machines. There is one machine out there called the Whale, appropriately named, that has 2, it's a single C-arm or closer to an O-arm almost, that has 2 different X-ray units mounted to it. But in looking at that, it really didn't meet our needs because we needed to have those be independent of each other. Right? Because I've got to have a lateral that's tuned to a certain degree, and I've got to have an AP that's tuned in both axes to a certain degree. And the only way to do that is to have 2 machines in the room at once. It just doesn't work any other way. If you had 2 C-arms mounted on, or sorry, 2 fluoroscope units mounted on one arm, you wouldn't be able to independently adjust them. So it would work well for placing a screw, for example, during a surgery, but it would work poorly for something like a PICL procedure. So you need, 2 C-arms that can be independently adjusted, and then I obviously got to know how to adjust them. It's been advanced by Ruth. I had a procedure done in Europe that I was told was the same as your PICL procedure. Yeah, it was not, Ruth. Having now listened to me or Facebook's, lives was definitely not. It took all of 10 minutes. The doctor did not use the imaging guidance you had talked about. Yeah, so if the doctor didn't use the imaging guidance I've talked about, it's just, in my humble opinion, suicidal, meaning that that's just nuts. How do patients protect themselves against these charlatans? They say it did not help. In fact, it made things worse. Yeah, well, that's why I do these Facebook Lives, right? I try as hard as I can to educate people. So obviously not using imaging guidance would be insane with something like a PICL procedure. So incredibly dangerous, I can't even fathom it. Trying to use just ultrasound, for example, during something like a PICL procedure would be suicidal. Trying to use one C-arm but not having any idea of what you're doing would be incredibly difficult and incredibly high risk. Trying to use 2 C-arms and not having an idea of what you're doing would be incredibly high risk as well. So that's why I did this one today, right? We're starting to see people that claim equivalence, but there's nowhere near equivalence. And I think patients need to protect themselves. So the reason why I'm on here every single week, as much as I can. There are times when I'm out doing other things, or I'm traveling, or I got family responsibilities, but I'm probably here 35, 40 weeks a year trying to educate patients so that they understand what these differences mean and how those differences go to the outcome of the procedure and the safety of the procedure. And it's not just these procedures, it's everything, right? You've got chiropractors out there that are hiring a nurse to start an IV and giving fake umbilical cord, in quote, stem cells, claiming that that's going to cure your low back. You've got, crazy naturopaths out there who were never trained how to do spinal injections, who are willy-nilly, injecting the spine and putting people at risk. Now, the average consumer can't tell the difference between all those things and someone that does something like we do it, unless we educate that consumer, which is why we're here today, right? That's why I do this and take the time to do it. Amen. Also, the doctor I saw said the cause of my pulsating headache was nerve coming out of C2. I think you mean the C2 spinal nerve. Yes, I think we've talked about how the C2 dorsal root ganglion lives in back of the C1, C2 facet joint. So it's possible that it's a C2 mediated headache. So that's a possibility for sure. Now, what would you want to do if it were that, right? You'd want to stabilize C1, C2 with something like a PICL procedure so the nerve isn't getting banged into. Then you want to treat the nerve directly, which you could usually do with an intra-articular injection of C1, C2 using an orthobiologic, not corticosteroid. Christy, are you actually training other doctors in the procedure? You won't be around forever. Yeah, I'm getting older, that's for sure. Yeah, right now we've got Dr. Schultz and Dr. Pitts trained. We'll be getting Dr. Merkel trained in our Colorado office. So we'll have 4 physicians probably by end of next year fully trained. Right now we have 3 physicians fully trained, myself, Dr. Schultz, and Dr. Pitts. And again, within a year or two, so if I get hit by a bus tomorrow, there's still 3 people in our office that can do this procedure. But long-term, yes, we want to train other people at other sites, but it's going to be interesting to see how many people step up to the plate, right? This isn't going to be a weekend course. This isn't going to be come in and watch something for a day and go home and try it. This is going to be, you need to spend weeks to months at our office learning how to do this procedure and being proctored in this procedure before we're going to let you ever try it on your own at home. And you're going to have to upgrade and spend millions of dollars, not thousands of dollars, but millions of dollars back home in order to do this safely, or at the very least hundreds of thousands of dollars to do this safely back home. So you're going to need to get a C-arm with digital subtraction. You need to buy a second C-arm to have it in the room at the same time. You're going to need to hire $100,000 a year rad tech to be in the room with you, and then make sure that rad tech is trained by our rad tech. You're going to need to process cells in a hyper sterile environment. So it's going to be interesting to see how many people are willing to do that, because that's not what doctors are used to, right? Doctors are used to going to a weekend course and calling it good. Well, that is way, way too dangerous for this procedure. Brian, I'm confused. Why don't you train anybody to do this procedure? You could license technique, make money, have several doctors working. Yeah, but the problem is, Brian, we'd have lots of injured, messed up people. The procedure would have burnt itself out by this point, meaning that the results would become so poor that no one would want to do the procedure. So again, we've trained 3 people in my office. So right now it's me, myself, Dr. Pitts, Dr. Schultz, and we're training a 4th person, which would be Dr. Merkel, to do this procedure. And we will certainly get it out there at some point. But it's not about making money. It's not about having 20 sites doing this. It's making sure that if another site does this out of Colorado, they do it right. And that's safe. And that's likely to work. And they know the dozens of different things you've got to know to make active clinical decisions when you're doing this procedure. Should I go this way? Should I go that way? Should I do this? Should I do that? I'm seeing this on the fluoroscope. What does that mean? What does this contrast pattern look like? Does that mean I'm in the ligament, or am I in a bursa, and it's not going to help this patient at all? So that's why we haven't trained more people. There's just too many moving parts. Amin, what's the best advice you can give to CCI patients if financially able to travel to the United States to attain a PICL? Don't know what to tell you there, Amin. I think the best thing you can do is what I do and tell people all the time. You know, you can use limited collar use. You can try to find a local doctor who does good, high quality upper cervical work. So for instance, we've recommended Ian Smith many, many times in the UK. He's got patients. I think I'm probably responsible for a chunk of his patient. I've never met the guy, but for a chunk of his patients right now, because he's got patients traveling all over Europe to get to him. So we try to do the best we can for those patients, but putting yourself in a situation where you're getting a potentially dangerous procedure is also not an appropriate thing to do. That's just taking too much risk. Are there other ligaments you inject from Robert via PICL outside of ALR and transverse? Yes, many others. I think we've talked about them several times on this show, but I'll throw some out again. The AAOM is injected. The SAAOL is injected. The C23ALL is injected. That's a whole separate procedure in and of itself, which we've dialed in from the PICL approach, which I've never even gone into on this show. We also frequently inject the anterior capsular ligaments as C0, C1. We inject the AO ligament, we inject the VDL, nuchal, obviously supraspinous, interspinous, upper neck facet joints, greater occipital nerve, lesser occipital nerve, third occipital nerve, superficial cervical plexus. So sort of a long, long laundry list. Robert, how long after new tissue is formed that these become mature and ready for more normal life activity? Yeah, Robert, I think 80% of what's going to be there happens in that first 3 to 4 months, and then you get remodeling. So in younger patients, that occurs much, much more quickly. So for example, we have lots and lots of MRI data on pre and post ACL injection in the knee, much bigger ligament, lots of imaging techniques on how to accurately image this ligament because it's imaged all the time. And I will tell you that in young patients at 3 months, it looks good to go. It looks like it used to before we injected it. But in older patients, someone who's got some age, I would call over the hill from an NFL standpoint, meaning we all see our NFL heroes drop out at around age 35. Some of them, like Tom Brady, maybe make until they're 40. But after that, they can't do it anymore because their innate ability to repair has gone down so much they can't they can't keep up with all the cumulative damage. So once you get into that NFL over the hill, post 40, 45, 50, sometimes it takes 6 to 9 months to see an ACL that's fully mature after a bone marrow injection. I don't know how to say that name, HF. Can the alar ligaments get loose over time in a hypermobile patient in the absence of any laxity posteriorly? Since ligaments in back are weaker, why would they get loose first before the alar gets loose? Well, the alar and transverse ligaments are much stronger ligaments because they are responsible for holding the head on and protecting the patient from getting a spinal cord injury. So in fact, the transverse ligament is one of the strongest ligaments in the body. Alar ligament isn't far behind. So that's why they tend to get loose less often than the posterior ligaments do, because they start out much, much, much stronger. So in that case, HF, the alar ligaments would be much stronger than the nuchal ligaments. Robert, key takeaway for the audience to understand when a clinic claims to inject C0 through C2, but really is injecting superficial. Ask if they use DSA if not run. Yeah, or so Robert, that's a great point to bring up for everyone that I think it's a good public service announcement. There's a couple of questions. So let's say we're talking about a C0, C1. A couple of questions you should ask. The first question would be, are you using a C-arm fluoroscope? If they say no, we use ultrasound, run, because that's super dangerous in my opinion. Second question you should ask, do you use contrast confirmation? So for instance, we've got a clinic in Florida that claims to use a fluoro, but they're not using contrast. They're just putting the needle somewhere near the joint and calling it good. So you need contrast to make sure you're in the joint. That's the stuff you inject. You can see it on the x-ray. You can say, yeah, I'm in the joint. Third question is, do you have digital subtraction angiography and do you use it? That needs to be a yes for all the issues we just talked about. Then the fourth question is, how many C0, C1s does this doctor do per year? And it needs to be at the least several a month, right? So dozens a year needs to be the answer. If they've only done a dozen in their career or 20 in their career, then you need to run. Meaning that doctors are no different than anyone else. Any activity that you do dozens of times a year, you get pretty good at. Any activity that you only ever done 10 or 20 times over 10 or 20 years, you're not very good at. And so it's the same thing here. Can patients request a mixture of BAC and PRP in a single injection for posterior injections during PICL? During my first PICL, I got PRP and the facets and ligaments didn't seem to help posteriorly. We always do the ligaments with bone marrow, so I don't think that's accurate. I think you probably got BMC plus PRP in your ligaments. As far as in your joints, we always start with PRP because most patients can't tolerate bone marrow in their joints, in their facet joints. Having said that, we move lots of patients to bone marrow if they can tolerate it. So it's just a matter of being able to tolerate that amount of inflammation in the joint. So the answer is yes to all of that. Amin, understood, no steroid injections. I will tell them directly by injecting PRP into the joints because PRP is the only solution available in Morocco. Sounds good. Jessica, why is it unsafe to get C0 injections in the Regenix facility? It's the only place Regenix advertises as capable of doing a safe C0, C1 is Centennial Schultz Clinic. And I'd recommend going back if you didn't see it and watch the earlier part of this video because I go through all of that in detail, meaning that there is no other place within Regenix that I would recommend right now for a C0, C1 for all the reasons I put into the video, early part of this video this morning. So if you could go back and watch that, I went through that in painstaking detail. I'm scared now. Should I stop taking corticosteroids now? You need to talk to your local doctor. I can't give you medical advice over the web. So you need to talk to your doctor about when you can stop taking corticosteroids. We do not prescribe prescription corticosteroids, oral corticosteroids for patients prior to injection procedures for all the reasons I talked about. It's well known that increases infection risk. So I would talk to your doctor about that. And if you want to send me a quick email, I can send you a link to a blog that has peer-reviewed publications that talks about why corticosteroids are a problem with injections. And maybe your doctor can read that, and then he or she can make some decisions based on reading that. Because most doctors haven't gotten that memo. They just haven't been talked to about that. Raj, hi doctor, is cervical instability the same as CCI? If the instability only involves facet joint, capsular ligaments, but not alar ligament, is that not classed as CCI? Yeah, Raj, there is no such thing as instability due to facet joint capsular ligaments. That was sort of made up by the prolotherapists who don't have enough direct education on how to inject into a facet joint. So they made up this concept that somehow capsular ligaments are responsible for instability. They are not. Instability is caused by the main ligaments. Now, you can have instability in other parts of the cervical spine. If it's in the upper cervical spine, C0 to C3, it's CCI. If it's below that, it's not CCI, it's just cervical instability. But the whole capsular ligament thing, be careful with that, because once a doctor starts talking about capsular ligaments and treating capsular ligaments, it's code in my book for that doctor has no clue what they're doing with regard to the advanced types of procedures that work the best to help patients heal from these injuries. Christy, what is the patient experience with PICL procedure? Christy, not sure what you mean there. Most of that stuff's online. There's a whole book. So I really think I'm trying to finish this out here in the next few minutes. So rather than going into what I usually say with that, if you can go and download the book on the centenoschultz.com website, that's the CCI 101 book. It's all in there in painstaking detail. Brian, sorry for any difficult questions, but it's hard being a printer for you when you sit down and take Q&A in your damn car. Yeah, I did that a couple weeks ago. That was pretty funny. You've got huge cojones. We all have much respect. You're laying out a legacy. Well, thanks, Brian. Yes, I've been doing that my whole career ever since I was the first human on earth to use culture expanded mesenchymal stem cells in a patient for orthopedic purposes back in 2005. So that has become a thing that I've gotten used to. Tasha, how long does it take for disc herniation to heal after injected? It depends on how it's injected. Can you get a disc herniation to heal after it's injected? You can. It would take months for the body to clean that stuff up, but it's a much more complex topic than that question and that answer. Meaning there are certain people you can help with disc herniations. Sometimes what's called a disc herniation is really a disc bulge. There are different ways to help them, different types of procedures, injecting in the disc, injecting in the disc annulus, injecting outside of the disc. So that's a really big topic that I didn't really do justice on answering there. Robert, worst patients equal. These are the ones that go wrong, chiro post PICL and get some thrusting or traction techniques or feel one day. Yeah, I think, Robert, you bring up an important point. Recovery in this case is about threading that needle, right? Threading that needle between staying as active as you feel able, but not doing too much. And we do see people that have a hard time threading that needle. They feel a little bit better, and then they go out and doing something crazy and they get injured again. Or they don't really understand the difference between, crack your neck type chiropractic and AO and NUCA, those sorts of things. Raj, what's the difference between PICL and EPICL? I got a whole video on that, Raj, but bottom line is EPIL means enhanced PICL. It's a newer procedure to get more and more reliably into more of the alar ligament. Raj, do you treat T4 syndrome? We do. And starting to run out of time, but I got all these questions here. Zigzag. I got elbow pain and electric shock sensation that goes to my forearm and towards my hand when I bear load, push up, bench press, pull up. Any idea causing this? That could be either an ulnar nerve entrapment, which would go here, or could be a median nerve entrapment, which would be from this part of the elbow and go into your thumb. So either one of those could be coming from your neck too. John, what traits do patients have in common they're able to fully recover from CCI? I think, as I've always said, the patients that we get within the first year to year and a half are amazing and how quickly they recover after a single procedure. Patients who have a typical presentation, in my opinion, also tend to do better. Typical presentation is I got in some sort of head trauma. I've had the symptoms like headache, dizziness ever since that head trauma. Then I've got, stereotypical imaging that fits into one of those boxes we often talk about here. Let's see. I'm trying to get to someone I haven't answered here. Lisa Marie, here's a random question. I have a DMX scheduled in 2 weeks and also due for a mammo, which I delayed for this DMX. How long do you think should I wait between the two? Yeah, I mean, listen, mammograms, if you've got cancer, obviously are extremely important. So I wouldn't put that off. If you're talking about a routine screening mammo that you're just pushing down the road a little bit, then, maybe put a few weeks between the two at most. Can PRP be used to treat osteoporosis in lumbar spine and hips? Cannot be, or at least not to treat the bone density. It can obviously treat the downside side effects or secondary effects of osteoporosis. Natasha, what are your thoughts on hormones and laxity? 49 years old, and my CCIAI worsened big time in the last couple of years. Knee dislocated subluxus correlates with cycle SI issues too. Yeah, I think there's probably some correlation there that we don't fully understand yet. For example, one of the independent things that could be affecting girls with ACL injuries is hormonal. So there's probably a hormonal component either to ligament laxity or to muscle activation that's causing more injuries in women in certain parts of their cycle. We also know that as women become postmenopausal, all hell breaks loose in the musculoskeletal syndrome in general, or a system in general. So that could also be causing issues. I'm trying to see if I can get to people I haven't talked that much to yet. Natasha, PICL procedure optimistic for positive results, 50-year-old over a decade of CCIAI with now with neuroepisodic paralysis, speech challenges, gait challenges. Yeah, Natasha, that's something I'd have to go through on a telemedicine visit with the person to give an accurate discussion there. Robert, I'm hearing from various pain management doctors, and right now, guys, I'm picking out questions based on their importance or if I've talked to someone already, just because we're getting towards the end here. I'm hearing from various pain management doctors that there's a shortage of dextrose, that they are in back order for a long time. Is this true? We have seen various shortages roll ever since the pandemic. So it's the first time in my career that we've ever had shortages of anything. And the answer is yes, there probably is a shortage of dextrose. We've been seeing problems with that. Now, if you've got a lab on site that, has sterile conditions, you can obviously go as a doctor and decide to aliquot a larger amount into smaller amounts. If you don't have that facility, then yes, this could affect you for sure. Tasha, are there any side effects or reactions to the anesthesia fentanyl used? No, not if they're used correctly. That's not something that we see. Jason, you mean the wrong traction technique? Yeah, you can use the wrong traction technique. So for example, a lot of our CCI patients will get traditional axial traction. It will really flare them up. That's a good example. I'm just trying to get to people I haven't spoken to yet here. Pia, does one have to stop blood thinner before PRP? Yes, in general, but it depends on the type of procedure you're getting. So for a PRP spinal procedure, maybe, depends on the blood thinner, depends on the patient. So those are all things you would have to talk directly to your doctor about. Christy, as far as steroids, what if the med you're taking is like Dolera, which is best practice for asthma treatment now, prevention instead of reaction? Dolera. Yeah, so that's an inhaled corticosteroid. So again, it's one that would have to be stopped. And we now know that inhaled corticosteroids are also associated with osteonecrosis. So so still increasing your risk by taking it long term. And the question then becomes, risk benefit, right? And that needs to be decided by the treating doctor. What's the risk of you getting osteonecrosis from taking Dulera versus what's the risk if you don't take Dulera? And if you're going to end up in the ER 5 times a year because you don't take Dulera, then maybe that risk outweighs the risk of osteonecrosis. So those are all individual decisions that get made patient by patient. But it's important that the doctor realizes that by putting someone on Dulera, they are increasing the risk for certain things so that they can accurately discern that calculus. Melanie, can PIC help for thoracic outlet or glossopharyngeal neuralgia? It can, or those things may need to be treated separately. Raj, thanks so much for your time. Come to London, you should do talks. I would love to meet you. Yeah, I'm in London twice a year, mostly to see my niece who lives in Cambridge. Jay sent me a traction, many kind of gotcha. Can the C1 facets help prevent C1 slipping forward? Not sure what that means. In general, the facets wouldn't prevent that slipping forward. Other ligaments would be responsible for that. Debbie, 20-year-old with heavy head, weak fatigue, neck worsening in the past year, hypermobility spectrum disorder, also Chiari. Would this procedure be something to consider? Yes. I mean, again, on a case-by-case basis, we're going to have to look at all the information. But that is something that it's a common patient type we treat with this procedure. Doctors are seeing lots of AI based on rotational CT. I don't use rotational CT to diagnose AAI. I find it extremely unreliable for that diagnosis, and it's poorly researched based on a Dvorak 1989 study. So I don't use rotational CT, but there are other ways to get to that diagnosis outside of rotational CT. McCartney could have whiplash injury cause CSF leak and AO instability. It was diagnosed with Chiari-1 that may due to CSF leak. Chiari-1 inflammation affect upper neck instability. Well, Chiari-1, just to realize, is present in a certain amount of the normal population that has no problems. So whether Chiari-1 is causing your symptoms is a good question. Can a whiplash injury cause a CSF leak? It can. Can it cause AO instability? It can. And can Chiari-1 malformation affect upper neck instability? You have that backwards. It's more upper neck instability can cause more symptoms in patients with Chiari-1 malformation than if the Chiari-1 malformation wasn't there. So it goes the opposite direction. Daniel, what can be done to treat arthritis on the left side of C1? If there's evidence of a bone bruise at the bottom part of C0, might you consider treating that? It's possible to treat that, but usually the bone bruise is there because of the instability. So you got to treat the instability, and then usually the bone can heal. Then my last question of the day here, because we're already 10 minutes over, just lots of great questions today. Kanchan, can any of the posterior ligaments prevent C1 sliding forwards when looking down? My head slides forward when I lean forwards. You can inject the posterior ligaments to help prevent that. That would be the nuchal ligament and the VDL ligaments. Also the PAOM ligament, which needs to be done only under fluoroscopy with contrast. It can't be done under ultrasound. And then the AO ligaments out here, again, only under fluoroscopy with contrast, can't be done safely under ultrasound. And then if that didn't work, and that was the only problem, many times it's not, then you would have to get some of the ligaments from the front that also are involved in stabilizing that atlas inflection. Okay, guys, thanks so much for watching. Again, topic today was just all the different parts and pieces that go in to these upper cervical injections or PICL injections. And hopefully I answered lots of questions. Again, the goal here is to try to get educated patients, because educated patients are the ones that usually get better quicker, because they understand, should I turn left? Should I turn right? How do I navigate this maze that we call the medical care system to my best advantage to make me better? And so that's why I do this as much as I can, so that we have more educated patients walking around out there than not. So you all have a great week. I will be here this next weekend, and probably same bat time, same bat channel. Probably going to do it around 9 o'clock Mountain Time, somewhere in there. Sometimes it goes to 10 o'clock Mountain Time on Sundays. So have a great week, everyone, and thank you for all your great questions.